Hello, dear colleagues. I'm glad to be invited at one more Pain Solutions conference. I'm Siniša Poznich, PNF instructor from Croatia, and through this presentation, which is called PNF Concept of Application in Neurorehabilitation, I would like to present PNF concept itself. Among the other similar neurofacilitation concepts, like Bobat is sure PNF concept belong to just to the side of Bobat concept, and then I can say that PNF and Bobat are the most famous and are standardized concept throughout the world for neurological treating neurological patients. Beside them, we have also the Czech concept, which is called dynamic neuromuscular stabilization, and also the other one, the Vojta concept, which treats babies with reflex locomotion. So it's primarily built for babies, sometimes for adults. PNF means proprioceptive neuromuscular facilitation. It's a physiotherapeutic approach where through movement facilitation with applying sensory information, we stimulate motor learning, aiming for more efficient motor control. Motor control nowadays is the most up-to-date and top topic in physiotherapy. So the PNF can be applied with neurological patients, orthopedic, also cardiorespiratory, pediatric patients, and also gynecological women health patients. We can say it's a non-formal postgraduate specialization in neurological physiotherapy and rehabilitation that can be applied also on other patients. The whole curriculum of PNF concept consists of 6 courses that last for 5 days. In total, that means 1 month of education. If we talk about concept history, this concept was developed in California in the United States, so it's an American concept in the early 50s of the 20th century. The founder was Herman Chabot, famous neurologist, in collaboration with physiotherapist Margaret Knott. Both of them can be seen on the bottom right picture. And first course was taught, postgraduate course was taught in 1951 in USA, in California, and in 1973 in Europe was the first PNF course in Switzerland. Talking about scientific background, so Herman Chabot took neurophysiological knowledge from the most famous neuroscientist at that time, Charles Sherrington, and for example, reciprocal innervation, irradiation, post-isometric relaxation, among the others, was his development. In 1990, IPNFA, or International PNF Association, was founded. Let's say a couple of words about PNF philosophy. As every concept has the same, PNF also has a philosophy, and we have 5 points which are important in this philosophy. First, I would mention positive approach in examination and treatment. That means that we try to look what is good at the patient first, and then we can, after that, we look what we can improve. And also the other point is we very often start with indirect treatment. That means we use some other body parts which are stronger usually to influence the weaker body part. We don't usually start with a weak body part immediately. Then it's a functional approach. That means it's oriented not only toward functions but toward activities and participations. And we seek for the most efficient participation the patient can achieve. Could be also with a prosthesis or in the wheelchair. We try to mobilize patient reserves. That means that every patient has untapped potential that we try to take from the patient with different motivations to help them, of course. Then a holistic approach, we don't only have in mind this injured body part, the physical part, but also we try to observe the whole person from the spiritual part of the person, psychological and also social, and in the end physical. And we use motor learning principles to influence motor control. So these 5 points we always have in our mind and when we treat it within a concept as a neurofacilitation concept. Components of PNF are philosophy first that I have just explained, then basic principles and procedures for facilitation. That means stimulation of through sensory system, for example, proprioceptors and exteroceptors, and using different procedures like motorics, like patterns are patient positioning, therapist positioning, so-called body mechanics, irradiation, and so on. We have different techniques using in PNF, actually 10 of them. For example, for learning a motion, learning a pattern, learning an activity, learning the position, then for mobilization, stabilization, for muscle relaxation, and coordination. So these are basics, these 3 points. And then we come to the point of examination and treatment planning, which is very common to the standardized I would say procedure of examination and treatment planning, but using up-to-date rehabilitation framework, which is called ICF, or International Classification of Functioning, Disability and Health. When we come to the point of the treatment, we use patterns facilitation or 3-dimensional movements facilitation on the table. We develop motorics from the floor, from supine or prone activities towards standing. Then we do different activities in sitting, and then we facilitate gait with different gait activities. And at the end, we also can facilitate vital functions like facial stimulation, tongue facilitation, swallowing, and swallowing facilitation, and breathing, of course. So this is general about PNF, and then let's present now the one case study, one neurological patient. He's a 32 years old male, a professor of Croatian language. In 2016, he suffered spastic tetraparesis because of brainstem bacterial infection spread from the non-treated tooth. And the clinical picture was very similar to the locked-in syndrome. From other conditions, he had bulbar motoric dysfunction in the sense of dysarthria, dysphagia, both eyes paresis, and face and tongue paresis. Cognitively, he was completely preserved, luckily. From assessment and functions of functions and activities, he is independent in the wheelchair, independent with eating and drinking, can walk 100 meters with moderate help of one person, his wife. He's able to walk 2 floors upstairs, down and two floors upstairs, but downstairs more difficult because inability to look down because of eyes paresis. His left arm is the strongest body part, so that's a good point for irradiation. But his trunk is, let's say, moderately strong or weak. His right leg is 3 out of 5, left leg 4 out of 5, and his right arm is in flexion, contraction of the elbow and wrist, so difficult to use. He lives with a wife on the 4th floor with an elevator, and they have no children at the moment. Defining activity limitation and causal impairment and testing. So, considering participation limitation, walking to the bar close to the building with the wife on the side. That's his aim. That's what is difficult from participation level, but possible. That means from this participation limitation, activity limitation is walking, and function impairment hypothesis. What do we think? What's the cause from the function level for this inability to walk? Is the lumbar spine stabilizers weakness? We can say 3 out of 5. When we test these activity limitation and function impairment, we can use a stand up and walk test for activity limitation with 10 meters, and for a lumbar spine stabilizers weakness, we can just use a supine to sit activity, and we count number of repetitions to see how strong our transversus abdominis. And then a couple of examples of exercises. I started with irradiation to stabilize, to activate transversus abdominis and back deep muscles with through legs, using stabilizing reversal technique. Then I use lower trunk pattern for rolling and also stimulating the trunk stability. And then I went to the direct treatment direct on the trunk using scapula and more direct using scapula and pelvis, also for to stimulate rolling. Then you can see the progression from position to quadruped position and working on the trunk stability there. Then progression from quadruped into kneeling position, stabilizing in a good position as good as possible, of course. Then from that position, half kneeling, so putting one leg in front, and then from you see from how the treatment can be developed from supine or prone into the more upright and getting closer to the activity level, which is walking. Then standing up, standing position, stabilization, and then doing some mobility on top of stability with the arm pedal. And at the end, we always, in PNF, we practice the activity level, which was in this case walking. At the end of the treatment, we do evaluation of tests, so that we repeat the same tests on a activity level and function impairment level. And then at the end, we give home program 2 to 3 exercises from the treatment, chosen from the treatment on the functional level, and 1 exercise on the activity level. So that was the short introduction of the PNF concept applied on neurological patients. Thank you for your attention. Greetings from Croatia. And if you have any questions, please later feel free to ask. Bye.